AFF to see how much sodium is entering the kidney, because whatever they enter, they know they will be reabsorbing all those. Does that make sense, folks? So they're like a scanner sitting next to AFF. Is that clear, folks? All right. Now, what happened in the event afferent arteriole has less blood flow? We call that hypoperfusion. In the event your kidney receives less blood flow, so I'm going to tell we are receiving less blood flow, so that means less sodium coming into the afferent arteriole. That cell, special cell in DCT, is called macula densa. The specialized cells, macula densa, already scanned. They scanned and said, we are not getting enough sodium into the kidney. So macula densa will send a signal to JG cells. They will send a signal to JG cells. JG cells will release renin. JG cell will release renin. You know what renin does. Eventually, renin will get you angiotensin II. That's the end product. Is that clear, folks? What is that angiotensin II will do? It somehow have to bring more blood to the kidney to get more sodium. That's all it is. Okay, so that's how it works. So now you could tell macula densa, DCT, JG, and AFF, they're all next to each other. You see that, folks? That's the idea, folks. Okay. Now, that's why anytime your kidney has low perfusion, you should have increased angiotensin system. Is everybody clear, folks? So you kind of have to know that, but that's why they're sitting next to afferent arteriole, so they could scan it and make a decision before it happens. Are we all clear, folks? All right. So that's that, okay? And JG cell, what type of receptor do we have in JG cell? Type it up. What type of receptor do we have? I only got one answer out of 14 people in here, or 13 people. Come on, folks. What receptor do we have in JG cells? What is it? Beta 1. Okay. Beta 1 is in there. Why do you need to know? So anytime you increase the sympathetic system, you will activate renin system too. Now we studied in pharm, right? Beta 1 agonist brings you renin, folks. So anytime we have sympathetic system comes in, so it's important, beta 1, okay? So that's the basic histology. Any question for me in this picture here? So you guys understand the location and everything, big picture, folks? All right. So that hypoperfusion is important, that concept, okay? All right. With this being said, let's do a little bit more anatomy here. Now, when it comes to ureter, right, it comes out of the kidney and goes all the way to the urinary bladder. So ureter is the connection between the kidney and urinary bladder. First thing we need to know, if I say this is your ureter, so let's say it comes off of the kidney. This is your kidney, for example. We call this proximal, middle, and distal. Each has its own blood supply. For some reason, this is becoming a hot topic now. You need to know who supply blood to the ureter. What's the function of ureter? It carries urine to the urinary bladder. They need oxygen for their cell to work. Ureter is formed of what type of epithelium? Transitional epithelium. Is a very unique epithelium, right? That's the one that can stretch and go back. So you should know who supply that. Kind of easy to remember. The proximal is next to the kidney, so they get it from the renal artery. And then when it comes to middle, it's a gonadal artery, aorta, common and internal iliac arteries. And then you have distal. You have to memorize, folks. You know, in anatomy, we don't ask question why, but it's what it is. So you have to memorize it, okay? That's that. The next thing to learn If you see ureter and uterine artery, they are so close to each other. You see how they are crossing each other. You see that. Now, when you see these structures in atlas or book, it looks so cool because it's a different color and all those things. In real patient, it is almost impossible to differentiate or even identifying folks because they are all inside the connective tissue. It's not easy. Okay, so they are next to it. There's a surgery called hysterectomy. Hysterectomy is a surgery that you remove the uterus. Before the hysterectomy, before we remove it, we need to go put a clamp of uterine artery. We need to block the uterine artery or ligate. You have to tie it before I remove the uterus. Why? If I don't cut this and I remove it, they will bleed in the abdominal cavity or pelvic cavity. Is that clear, folks? So they ligate, what we call. If the surgeon is not careful in the real patient, they could put a clamp like that. You see that, folks? You would ask me, how can somebody make a mistake like that? In real patient, it's almost easy to do that, folks, okay? They have to be careful. So when they ligate, what happens? Nothing happens. You ligate, patient's uterus comes out, hysterectomy is successful. Then what will happen? The urine output will not be normal afterwards. They will have a decreased urine coming in. Is everybody clear, folks? I mean, coming out of the patients, okay? So that's one of the complications. That's why if you see that most of the OB-GYN surgeons, because OB-GYNs are considered surgeons, they do this surgery. After hysterectomy, they are always paranoid until they see the urine output is within the normal range, because that's one way of reconfirming they did not block the ureter. Because in case if they block it, what happens? You have to reopen the abdomen because you have to remove it, right? Go so fix the problem. So that's something you have to be careful that they ask you in the exam. Gynecological procedure, ligation of a uterine and all this thing can damage. Okay, so sometime you should know that. Okay. Now, if you see the other anatomy here, folks, bladder contraction compress the intramural ureter, preventing urine reflex. Okay. Now, we will talk about that when we do urinary incontinence. Okay, so we have to talk about the mechanics, how urine comes. Those are part of the bladder. We will keep it separate. Okay, I'll talk about that. All right, so that's about ureter, what we need to know. In this picture, you could see the ureter. That's, we could almost say, that's your proximal, middle, distal. Okay, so that's that part, folks. All clear so far? All right.
So the significance of hysterectomy is just bleeding in the abdomen if you don't
just
like it.
Basically, when they ligate the uterine artery, they have to make sure they do not ligate ureter. Of course, it's not happening very commonly because OB-GYN knows what they are doing, but theoretically speaking, it's always possible to make that happen. All right. Now, some physiology. Okay. In endocrine, we already talked about isotonic, all these things, isn't it, folks? We talked about it, right? So that means here we just wanted to know there's something called 60-40-20 rule, just to know. 60% of your total body weight is water, folks, okay? 60% is total body weight is water. That's like, if somebody's 100 pounds, 60 pounds is of water in that, folks. Okay, now sometimes some people do certain diets, they just lose the water. Of course, when you weight yourself, it seems like you lost weight, but it is not actual fat. It's actually fluid you lost. It will be reabsorbed very easily after a few days. Okay, so that's 60%. And then you have 40% of ICF and 20% is ECF. So nothing clinically significant in here, folks, okay? Now, I already discussed about what is osmolarity and how they maintain ADH in relationship into all those things, folks, okay? All right. So the next most important thing here, glomerular filtration. This is anatomy. We are not talking about GFR, we are talking about the barrier. I will put a star here. If you don't understand this, nephrotic syndrome or nephrotic syndrome will never make any sense, folks, okay? I think this is the most important that you need to learn to understand nephrotic and nephrotic. People think nephritic and nephrotics are difficult. Actually, it's not. Because when you don't know this, that becomes difficult. So let's go ahead. And I want you guys to draw this and label it as I am doing it, folks, okay? That's your glomerulus, AFF, EFF. Okay. That's a basement membrane. I just put 3 fenestrations, okay? Let me explain, and then you can continue writing. I'll give you time. So what I did, afferent arteriole and efferent arteriole, this is the basement membrane. When it comes to kidney basement membrane, they're very special because this basement membrane has something called glycosaminoglycans and heparan sulfate, not heparin medication. This is heparan, okay? Heparan sulfate. They both are negatively charged. It's very important. What does that mean? If they are negatively charged, anything that negatively charged in the blood cannot go out. Does that make sense, folks? Okay. Now, what is this fenestration? I put it on a black color. Fenestration is a fancy word, okay? Fenestration is a fancy word for a hole or little pores, okay? We could call hole, pores, simple, little pores, so the things can go from the blood vessel to get filtered. So the filtration actually happened from the here, it goes, and then that's how the fluid comes in this way. Is everybody clear, folks? All right, go ahead and copy that.
The first part is heparin or heparin?
Heparan sulfate. HEPARAN, heparan sulfate. And on the top, I wrote glycosaminoglycans.
Thank you.
So basement membrane, tag, and then all of them are negatively charged.
Yeah, negatively charged. And I'll tell you that specifically this structure, what we are talking, it's applicable to kidney basement membrane and alveolar basement membrane in the lungs. Okay. There's a reason we bring lungs in here. Just think lungs and kidney has a very similar structure. So everybody clear here, folks? Now, the fenestration, right? That's what I'm very careful with that. The fenestrations, they are, let me erase those. These are small pores that they filter, all the stuff comes through that. Okay. Now let me erase this. Now you also wanted to name things here. I'm going to put a small dot. These are small dots, okay, just to make it. And then I also have a big dot. The small dots are called albumins. Big dots are called globulins. Albumin and globulins, they are all protein. The difference between albumin and globulin, the size. One is very tiny, the other one is bigger. So we have two different type of protein, folks. Now remember, this protein is in the blood. That's blood, right? That means this protein is everywhere in your body. Wherever there's arterial system or venous system, you have these two proteins. And these two proteins are important for us to live, especially albumin. Without albumin, we will not be able to survive. Okay, everybody done with this picture? Now, when you see albumin and globulins, let's talk about this. If you notice it, globulin, if I ask you how come globulin is not coming here in the filtered area, the answer is they are big in size. They cannot enter through small pores and come out. Does that make sense, folks? So the globulins don't come in the urine is because of the size. So we call that size barrier. It's because size barrier. So we should never see globulins in anybody's urine because they are big, so they should not be filtered because it's a size barrier. Is everybody clear, folks? Okay, that makes easy, common sense. Now let's talk about albumin. If you see albumin, folks, you see they are way smaller than the pores. Is everybody clear, folks? They are way smaller. It can easily get in here and come out in the urine. But is it normal to see albumin in the urine? No, you should never see any protein in the urine. So the reason we don't see albumin in the urine because it's a charge barrier. What does that mean? Albumin is also negatively charged and the basement membrane is also negatively charged. So they don't allow protein, especially albumin, to be filtered. So we call it charge barrier. So the nephron, your glomerulus, has two types of barrier, size barrier and a charge barrier. Is everybody clear, folks? So I recap. If somebody asks you, how come we don't see globulin in the urine? It's because of the size barrier, because they are big in size, cannot go through the fenestration. How come we don't see albumin in the urine? Even though they are smaller, because of the charge barrier, they cannot be filtered. So that's what we call size and charge barrier. Is everybody clear, folks? Okay. Now, that's so important. This is the reason we should not see any protein in the urine. If you see a protein, that's pathology. Are we all clear, folks, here? All right. Now, because we are studying, I want to give a big picture. There is one disease, okay? Don't say it. If you know it, you will type it. There is one disease. What happened in that disease? They only lose the charge. They kind of lose the charge. When they lose the charge, what would I see in my urine, folks? Albumin. Does that make sense, folks? So how do I write that? I'm not going to just say albumin. I'm going to say selective albuminuria. Selective albuminuria means in this patient, they only have albumin, nothing else. Does that make sense, folks? So the minute patient has selective albuminuria, you should know nothing happened to the size, only they lost the charge. Is everybody clear, folks? If I say I have globulin, then you could say, oh, they lost the size too, right? So who can type the name of the disease? They only lose the charge and they have selective albuminuria. If I say the name, you guys will be like, oh, this is what it is. So that particular disease is selective albuminuria, where they lose just the charge, nothing else. Have you heard a word called minimal change disease? Ah, look at Mallory. She's like, yeah. So what is minimal change disease? In minimal change disease, you just lose the charge and people have selective albuminuria. Okay, that is a good example for that. Okay, in minimal change disease, we should know they shouldn't have anything other than albumin. Is that clear, folks? Because it's a charge loss. Okay, so that's the idea. Now, just to go one step ahead, you could lose either charge alone or you could lose size. But the problem is when you lose the size, you would technically lose the charge too, because that means there's a big damage is happening in the fenestration. Is that clear, folks? Anytime they lose size, they would also lose the charge, or they could just lose the charge. Is everybody clear, folks? All right. Now, if you go back to the book, Look at this. The glomerular filtration barrier is responsible for filtration of plasma according to their size and charge. Okay, now you could see what are those composed of. Fenestrated capillary endothelium. In my drawing, I didn't do the endothelium. It's right here, okay? Inside the blood vessel, you have endothelium. Now you have a basement membrane. Okay, this is important. You should also write it. It's a type 4 collagen. Basement membrane has type 4 collagen, okay? Here you could say that's your type 4 collagen. Type 4 collagen in there. And that also has heparan sulfate. You see that here. Heparan sulfate. And then you have visceral epithelial layer of podocyte. It is not something very important to learn, but if you see, where do I go? You see here, folks, there's another epithelium inside underneath it. It's called podocytes, okay? You just need to know there's a visceral podocytes. They are right there. And the filtration happens in between the podocytes, folks, okay? That's all you need to know. There's nothing else to learn in there. So that's...
I have a quick question. Like, which of these endothelial layers or epithelial layers is affected if there's globulin that's coming out due to its large size?
What do you mean, which of these layers?
The filtration barrier page.
So the filtration barrier, remember, when people lose globulin, so you need to know whether we are losing size